what can you tell us about the mental benefits of testosterone replacement?
Hi, Stephen. Nice seeing you again, and thank you for having me again. I'm always so excited to do those talks with you.
Great to have you back. And today the question was, what can you tell us about the mental benefits of testosterone replacement?
Very good. Stephen, I think this is such an important topic and something that really I don't hear people talk a lot about. Even when I go on YouTube and I type testosterone and depression, there's really or testosterone in the brain. There's not that much available. And, experience with testosterone, both personally and for the thousands of patients that I've treated, is to me, the mental benefits of testosterone are even more important than the physical and the sexual benefits. And what's hard to delineate with this is that sometimes those improvements are very subtle. So what I'm noticing with a lot of my guys, I call my patients my guys. When I do my follow-up consultation with them, sometimes I get this. I'm like, how you doing with the treatment? They're like, oh, I'm doing pretty good. I'm stronger at the gym. My erections are better. I'm like, that good. I'm like, what about your mood? And they didn't pay attention to it. But once I start asking questions, and I know now what questions to ask, they'll tell me, you know what? Yes. My coworkers are saying that I'm nicer. My wife says I'm less irritable. I tend to enjoy things I wasn't enjoying before. So this is a constant thing that I'm getting with my patients. And when I go to a lot of the, testosterone conferences, the anti-aging conferences, this is a comment we see almost every doctor treating low T is telling you this. There's a lot of our patients come to us with low mood symptoms. They may not amount to major depression, but it's a decreased quality of life. So once I started doing this, of course, I went and I reviewed the literature to see what's available. So when we look at it, first, it's really difficult to replicate studies in a randomized controlled study to see the effects of depression, because there are so many variables of what affects mood, affects anxiety, that it's sometimes very difficult to replicate this. But most studies from the 1930s until now are showing a bidirectional relationship between testosterone and mood, meaning that patients who score high on depression symptoms tend to have a lower testosterone level, and the opposite is true also. Patients with lower testosterone level tends to have more depressive symptoms. Again, may not rise to the DSM-5 diagnosis of major depression, but it tends to be low overall. The words I hear a lot from patients, and that we see in studies also, it's decreased ambition, decreased quality of life, decreased zest. So those are things my patients tell me, and that they replicate also a lot in studies. And what got me excited when I looked at the literature, there's an amazing article that was published in JAMA Psychiatry in January 2019. I wasn't aware of it, although I've been prescribing testosterone for 10 plus years. I never really looked at that study until I really went deep into looking into testosterone in the brain. And that study was amazing. So it's in JAMA Psychiatry. They reviewed 27 randomized controlled trials. And the title of the study, actually, I have to read it. The title of the study was Association of Testosterone Therapy with Alleviation of Depressive Symptoms in Men. So the title says it all. They studied, out of those 27 studies, 1,890 men. So 1,890 men. And they saw, same thing I just said, that patients in the lower quartile of testosterone tended to have more depression, anxiety, lower quality of life scores versus patients in the higher quartile. And patients also who tended to have depression tended to have lower levels of testosterone. And so they did the studies, and they saw that, and that was amazing to me. Men with lower testosterone level, and again, they did not define that it's less than 300, they said lower quartile. When you replace testosterone in those men, they had 2.3 times possibility of having reduction of their depression symptoms by 50%. 2.3-fold. This is a huge number. How many, even in your practice, every physician we see that, once you start talking to your patients, Especially, once you're in your 40s, 50s, every person carries some weights from life, except if you're a very strong person mentally, you have positive spirit, positive mind. Everybody, as we get older, we have a little something that kind of gets us, that kind of gets our life maybe not to be optimized. And what I'm realizing with my patients and what I'm seeing with those studies, testosterone replacement helps with this. It helps with ambition, helps with drive, it helps with gaining social status. So guys on testosterone will tell you this. I have many patients who gave me testimonials. They said, Doc, once I went on testosterone, my performance at work increased. I got a job. I have a patient who gave me a testimonial. He was a corporate lawyer. He was in his late 30s with low T. He said he worked in his corporate job. He never had the guts to open his own clinic. Once we optimized his testosterone and really kind of helped coach him, he opened his own clinic. He really had the ambition to push it. Because remember, Stephen, testosterone is what really makes us more alpha. And alpha, to me, although there may be some negative connotations to alpha sometimes, but there's no question that alpha thinking tends to lead to more leadership roles, better interaction. Testosterone, there's a lot of studies they did in Europe where they really looked at the interaction with testosterone and social status. And they did that both in humans and in primates. And it sees that optimizing testosterone and testosterone replacement, what it does, it doesn't really increase aggressivity. It mostly what it does is that you want to achieve a higher social status and maintain it. And this was seen in every form of life, from primate even to invertebrate that have testosterone. So testosterone is the will to power. But when I say power, it's not power in a negative way. It is power in a self-expression, self-realization of the human spirit.
Yeah. So a lot of GPs who see men with maybe a bit of depression, sometimes they don't think about testosterone. They immediately prescribe SSRIs. So you always propose to do a testosterone level check first, probably.
Well, and that study from JAMA Psychiatry, that's what, so of course, researchers are always going to be very cautious. They're always going to see at the end of the study that there was a 2.3-fold increase for men to have reduction of testosterone symptoms, but we need longer studies. And I agree with this, we do need longer studies. But now we have that study, amazing, plus we have all the anecdotal studies of all of us physicians treating our patients that see that it works. I counted with my clinic. We took off SSRI from 75 men out of our clinic, meaning men who came to us, and now a lot of psychiatrists even refer to me, and they come to me with depression, either on SSRI or failed SSRIs. And of course, testosterone is not just the panacea. I think we say that a lot. You say that a lot. It's a tool. It's a very powerful tool. But on a lot of my patients, when they come to a lower level, and we put our coaching that includes nutrition, exercise, mindset, and hormone balance. Again, I've had 75 to 76 men I was able to, with the help of the psychiatrist, of course, get them off the SSRI. Mm-hmm. So when we look at SSRI depression treatment in general, this is what's amazing to me. Psychiatry, it's a branch that I hate, but that I love. I love it because we can make such a difference in people's lives if we can help them change their perception, their mood, and their ambition. We can do a lot with this. I hate it because there's nothing objective in psychiatry. I like that you can go and you measure a blood test, you do a CAT scan, you see a problem, you go after it, and you fix the problem. Psychiatry is not like this. You come in, like the MD, psychiatrist or internist does an interview, try to go with some specific questions and try to come up with a score. But it is very subjective. And based on this, we decide whether the patient has depression or not. But it is up to the discretion of the physician. Once you say, oh, maybe that patient has discretion, it's okay for you to start an SSRI without any objective testing. To me, this is tough to be a psychiatrist, because you just throw that medication. And as we know now, the studies of long-term use of SSRIs are showing a lot of long-term side effects, increased risk of diabetes, increased risk of chronic kidney disease, even some structural changes to the brain. So I don't think our first instinct when you have somebody, especially if it's not major depression, you know, a typical man who comes in with midlife crisis, low energy, low libido, mild to moderate depressive symptoms, our first option should not, let's go SSRI. So in my practice, and I see that this is happening more, and my goal into writing my book and appearing on different podcasts is to, again, we talked about that, Stephen, to bring that empathy, that human touch to medicine again. So when I sit down and talk to my guys, they'll tell me they just had a physical with their primary. I got flying colors, everything's great. And they'll tell me, but doc, my life is, it's not the same. I got to push to do the things I used to do. I don't enjoy them as much. And you listen to them. You're like, okay, let me see what you're enjoying. You check a level. On my patients that have the lower quartile, again, whether it's less than that 300 range or just on the low end of testosterone, on a lot of those guys, replacing testosterone will give them a positive impact. Maybe not complete resolution of symptoms, but most guys will get some improvement. So when you look, if you do column A and column B, somebody comes to me and they have depressive, I don't even like to say depressive symptoms because it has a negative connotation. I like to say decreased quality of life symptoms. You don't enjoy what used to give you joy the same. You don't want to lead or perform like you used to. You just, we call it anhedonia. You don't get pleasure in what used to give you pleasure. And it's a spectrum. There's people who are all the way at the bottom, or even if you're at the middle. I want to live my life at the top of the pleasure. And when I mean pleasure, it doesn't mean pleasure of the outside pleasures, but realizing what I can realize. I want to be able to get up in the morning, have a pep in my step, want to achieve things, whether it's at work, at home, at the gym, at the sports. So this, to me, is what we want to maintain as we get older. So really, when a lot of those patients come, we're like, okay, here are your symptoms. We have two choices. We can either put you on medication A, that studies show that you have maybe 35 to 40% improvement of your symptoms, but you may feel very numb and detached. You may have sexual side effects, and long-term it's been shown to have problems with diabetes and all this. Or we can go with drug B, that the studies for long-term use are the same as the SSRI. We may not have long-term study on testosterone, 20, 30 plus years, but short-term we know that it's safe. In like I just cited that study, 2.3-fold possibility of having 50% reduction of your symptoms. And on top of this, you're going to get better physique, you're going to have better sex and better libido. Let's choose. Which one do you want, A or B?
Easy.
Right?
Yeah, easy. Yeah, great answer, Rudy. Thanks.